Welcome to the training series on the Mental Health Services Act, or the MHSA. This is the first part in a multi-series training on the MHSA and how it is implemented in Sacramento County. Before we start reviewing the MHSA 101 information, I'd like to walk you through how the information is organized in this first part of the training series. I will provide you with a high-level overview of the Mental Health Services Act, or MHSA, formerly known as Proposition 63. This will include history about the MHSA General Standards, a high-level overview of each of the 5 MHSA components, and MHSA-defined populations. I will then provide details on MHSA funding allocations by component and funding rules. There will be a brief overview of stakeholder involvement, followed by taking a deeper dive into each of the 5 MHSA components, where you will learn about each component's purpose, population, goals, and the component's funding or service categories. I will review how the MHSA 3-year program and expenditure plans and annual updates are developed and finalized for submission. Finally, I will provide information about 2 external organizations that are involved with the implementation of the MHSA across the state. Decades ago, the state cut back on services in state hospitals for people living with serious mental illnesses, but did not provide adequate funding for community-based mental health services. Cuts to federal Medicaid during the 1980s further devastated the public mental health system. These cuts prevented tens of thousands of Californians from accessing much-needed mental health care, which led to increased homelessness, hospitalizations, and incarcerations. To address these gaps in services, voters passed Proposition 63, the Mental Health Services Act, or MHSA, in 2004. The MHSA places a 1% tax on personal income above $1 million. Since 2004, it has generated millions of dollars for the public mental health system of care. The MHSA is intended to transform and expand mental health services in California to provide a better coordinated and more comprehensive system of care for individuals living with serious mental illness or serious emotional disturbance. It is also to define an approach to the planning and delivery of mental health services that is embedded in MHSA values or the general standards. The MHSA sets forth 6 fundamental concepts that are to be included in all MHSA-funded programs and activities. They are designed to ensure that through MHSA-funded programs and activities, counties work collaboratively with their communities to create culturally competent, client and family-driven mental health services and support plans that are wellness-focused and support recovery and resilience, and which offer integrated service experiences for clients and families. Now let's take a look at each concept. Community collaboration. The goal of community collaboration is to bring members of the community together in an atmosphere of support to systematically solve existing and emerging problems that could not easily be solved by one group alone. Cultural competence. These are behaviors, attitudes, and policies that come together to enable service providers to work effectively in cross-cultural situations. Service providers understand and utilize strengths of the culture and service delivery. Identification, development, and the implementation of culturally competent best practices must be an integral part of ongoing MHSA planning and implementation. Client-driven. Adult clients identify their needs and preferences, which lead to the services and supports that will be most effective for them. Their needs and preferences drive the policy and financing decisions that will affect them. Adult services are client-centered, with providers working in full partnership with the clients and families they serve to develop individualized, comprehensive service plans. Family-driven is similar to client-driven, but instead it's the families of children and youth identifying their needs and preferences, which lead to the services and supports that will be most effective for them. And these needs and preferences drive the policy and financing decisions. Child and youth services are family-driven, with providers working in full partnership with children, youth, and families they serve to develop individualized, comprehensive service plans. Wellness, recovery, and resilience. Recovery refers to the process in which people who are diagnosed with a mental illness are able to live, work, learn, and participate fully in their communities. For some individuals, recovery means recovering certain aspects of their lives and the ability to live a fulfilling and productive life despite a disability. For others, recovery implies the reduction or elimination of symptoms. Concepts key to recovery are hope, personal empowerment, respect, social connections, self-responsibility, and self-determination. Resilience refers to the personal qualities of optimism and hope, and the personal traits of good problem-solving skills that lead individuals to live, work, and learn with a sense of mastery and competence. Research has shown that resilience is fostered by positive experiences in childhood at home, in school, and in the community. Lastly, integrated service experience. This means that services are seamless to clients and that clients do not have to negotiate multiple agencies and funding sources to get critical needs met and to move towards recovery and develop resiliency. Services are delivered or at a minimum coordinated through a single agency or a system of care. The integrated service experience centers on the individual or family using a strength-based approach and includes multi-agency programs and joint planning to best address the individual or family's needs, using the full range of community-based treatment, case management, and interagency system components required by children, transition-age youth, adults, and older adults. There are 5 distinct components to the MHSA, and each component has its own purpose, funding, and rules. This slide provides a high-level description of the purpose of each component. Through the Community Service and Supports, or CSS component, counties may provide direct services and supports for children, transition-age youth, adults, and older adults and their families who have the most serious mental health needs. Through the Prevention and Early Intervention, or PEI component, counties may provide prevention services that promote wellness and prevent the development of mental health problems. And early intervention services are to screen and interview and intervene in early signs of mental health issues. Through the innovation component, this provides opportunities to try out or test new approaches on a time-limited basis that may improve access, collaboration, and/or service outcomes for all mental health consumers with a focus on the unserved, underserved, and inappropriately served populations. Through the Workforce Education and Training, or WET component, counties may build, retain, and train a competent public mental health workforce. The Capital Facilities and Technological Needs, or CAPFAC and Tech Needs component, provides counties with the opportunity for infrastructure development for appropriate facilities and implementation of technological infrastructure to provide mental health services. We will take a deeper dive into each component later in this session. The MHSA is intended to increase access and services for underserved, unserved, and inappropriately served populations in the following age groups: children and youth age 0 to 15, transition youth or TAY age 16 to 25, adults age 26 to 59, and older adults age 60 and up. MHSA funding is quite complex and complicated, requiring that counties carefully track every allocated MHSA dollar from the time it's received, then budgeted, and then spent. And because MHSA funding is tax-based on high-income earners, revenue is highly volatile. Before I launch into reviewing MHSA funding information, you will notice that in the bottom right-hand corner of each MHSA funding slide, there is a pie chart. This illustrates how one MHSA dollar is divided by component. Each component has a specific funding allocation and funding rules. Let's start reviewing the Community Services and Supports, or CSS, component funding. As you can see in the pie chart, 76 cents of an MHSA dollar is directed to the CSS component. Some funding rules about the CSS component funding include the following. A majority of CSS funding must be directed to full service partnerships, or FSPs, which is a service category within the CSS component. Unspent CSS funding combined with incoming CSS revenue sustains current CSS funded services and may fund services resulting from successful innovation component projects. Of note, services from successful innovation projects must align with CSS component purpose to be sustained with CSS component funds. Lastly, unspent CSS funding may be used to sustain MHSA housing program investments. For the Prevention and Early Intervention, or PEI component, if you look at the pie chart, 19 cents or 19% of an MHSA dollar is directed to PEI. And a majority of these funds must be directed to PEI programs and activities that serve youth and TAY. Similar to CSS component funding, unspent PEI funding combined with incoming PEI revenues sustain current PEI funded services and may fund services resulting from successful innovation component projects. Again, of note, services from successful innovation projects must align with PEI component purpose to be sustained with PEI component funds. As mentioned earlier, innovation component projects provide time-limited opportunities to try out or test new approaches. Once they are developed through the community program planning process, there are several layers of approvals before a county can implement it. It must be approved by the local Board of Supervisors. It then must be approved by the Mental Health Services Oversight and Accountability Commission. They are a state commission that has oversight of all counties' innovation plans. We will learn about them later in this training session. Again, looking at the pie chart, 5 cents or 5% of each MHSA dollar is directed to innovation component projects. As previously mentioned, once innovation projects are completed, if it is successful, counties may sustain the services from that project with another fund source. Should the services align with either CSS component or PEI component purpose and requirements, and should component funds be available, counties may sustain services with that component funds and with community support. Early on in the implementation of the MHSA, both the Workforce Education and Training, or WET, and Capital Facilities Technological Needs components were both funded with one-time allocations. And these one-time allocations were to be spent by fiscal year 2017-2018. And there was also one-time funding in 2008 for acquiring, rehabilitating, or constructing permanent supportive housing for individuals living with serious mental illness and to provide operating subsidies. Beginning in fiscal year 2008-2009, counties may dedicate up to 20% of the average of their 5-year total of MHSA funds to sustain current or develop new WET component actions, to sustain current or develop new CAP-FAC tech needs projects, or to their local prudent reserve. Additionally, counties may use up to 5% of their total annual MHSA revenues for planning and supporting consumers and family members, stakeholders, system partners in local community program planning processes. The MHSA specifies several funding rules. The MHSA specifies that MHSA funds cannot be used to supplant or replace existing state or county funds for mental health services that existed prior to 2004. The state cannot decrease its level of financial support for mental health programs. And MHSA funds cannot be used to pay for services in long-term hospital and/or institutional settings or involuntary settings. Therefore, MHSA funds may only be used for services that are received voluntarily and that are community-based. Another important funding rule is reversion. The MHSA specifies that funds must be spent within a certain period of time or returned to the state. CSS, PEI, and innovation component funding must be spent within 3 years of allocation. WET and CAP-FAC tech needs components initial allocations must have been spent by 2018. However, funds dedicated to the local prudent reserve are exempt from reversion. The local prudent reserve. Each county is required to establish and maintain a local prudent reserve, also known as a rainy day fund, to ensure that MHSA services do not have to be significantly reduced in years in which revenues are below the average of previous years. So the prudent reserve is meant to protect counties' core MHSA services in the event of an economic downturn. Counties can access local prudent reserve funds only with the State Department of Healthcare Services approval. Prudent reserve is limited to 33% of the average CSS revenues received in the preceding 5 years. And again, prudent reserve funds are not subject to reversion. meaningful stakeholder involvement. It is legislated that all MHSA-funded programs and activities come through the community. The MHSA intends that there be meaningful stakeholder involvement in the MHSA community program planning processes. MHSA-funded initiatives should engage the following stakeholders: consumers, family members, providers of mental health services, law enforcement agencies, educators, social services agencies, veterans and representatives from veterans organizations, providers of alcohol and drug services, healthcare organizations, ethnic and cultural community members and providers. And the second part of this training series, Sacramento County's program planning processes, will be reviewed in depth. There are 5 distinct components to the MHSA, and each component has its own purpose, funding, and rules. Note that each component also has specific funding categories, also referred to as service categories or actions. This just means that each specific component will fund specific types of programming and activities. As each component is reviewed, I will review the component's purpose, goals, and funding or service categories, and I will also re-review some of the component's funding requirements as previously reviewed. The first component we will review is the Community Services and Supports component, also known as CSS. The purpose of this component is to provide all necessary mental health services to children, TAY, adults, and older adults who are experiencing serious mental illness, and for whom services under any other public or private insurance or other mental health or entitlement program is inadequate or unavailable. The CSS component programs are intended to address the following domains: to ensure safe, adequate housing and reduce homelessness, reduce psychiatric hospitalization, reduce incarceration, increase timely access to needed services, including crisis services, to increase meaningful use of time and capabilities, including education, employment, social, and community activities, to increase network of supportive relationships. And CSS-funded programs are intended to serve children with severe emotional disturbance and their families, TAY adults and older adults living with serious mental illness. As mentioned a few minutes ago, every component has funding or service categories, which are types of programs and activities that can be funded within each component. This slide outlines the CSS funding or service categories. The first service category is full service partnerships, or FSPs. FSPs are high-intensity mental health treatment programs that provide a broad range of coordinated services and supports that assist clients in their recovery. FSPs provide a whatever-it-takes approach to services and supports. The General System Development Service category includes programs that improve the delivery of mental health services and supports for clients and their families. And the Outreach and Engagement Service category includes activities that reach out to unserved and underserved communities to connect them to appropriate mental health services and supports. CSS funding may also be used to sustain counties' MHSA housing program investments. CSS also funds administrative costs, which include costs associated with monitoring and evaluating MHSA-funded programs, activities, and projects, and costs associated with conducting and facilitating community program planning processes. And here are some CSS component funding highlights. At least 51% of MHSA CSS component allocation must be dedicated to full service partnerships or FSP service category. Many CSS services are also eligible to bill Medi-Cal. MHSA funds may also be used for non-Medi-Cal eligible expenses such as non-mental health services or supports. Examples of those include rent, utility bill, food, etc. So in other words, counties may braid MHSA CSS component funding with Medi-Cal. As mentioned before, county MHSA funding for CSS is 76% or 76 cents of an MHSA dollar. Now we'll learn about the prevention and early intervention or PEI component. The purpose of the PEI component is to engage persons prior to the development of serious mental illness or emotional disturbance, to alleviate the need for additional mental health treatment, to transition those with identifiable needs to extend mental health treatment, and to reduce stigma and discrimination. The intent of all PEI programming is that individuals are referred and linked to ongoing mental health services when it is indicated that they are needed. PEI programs are intended to reduce the negative effects of untreated mental illness, including suicide, incarceration, homelessness, school failure or dropout, removal of children and older adults from their homes, prolonged suffering, and unemployment. The PEI regulations stipulate that 3 strategies are incorporated in all PEI component funded programs. These strategies include access and linkage to treatment and other needed services, improving timely access to services for underserved populations, and stigma and discrimination reduction. Populations intended to be served through PEI-funded programs are individuals prior to the onset or development or at risk of developing serious mental illness or severe emotional disturbance, including underserved cultural populations, individuals experiencing onset of serious psychiatric illness, children and youth in stressed families, trauma-exposed individuals, children and youth at risk for school failure, children and youth at risk of experiencing juvenile justice involvement, parents, caregivers, and other family members of the person experiencing early onset of a mental illness. There are several PEI component funding or service categories, and they will be reviewed one at a time. As each service category is reviewed, keep in mind that the regulations require that most all PEI programs services are time limited. The first service category is prevention, which are programs that prevent the occurrence, severity, consequences of serious mental illness for individuals with identified risk factors or for groups of individuals with demonstrated greater average vulnerability to mental illness. Early intervention programs are time-limited services for individuals with early onset of serious mental illness to provide mental health outcomes that include recovery, resilience, and wellness, and to assist them in quickly regaining productive lives. Outreach for increasing recognition of early signs of mental illness programs or activities include conducting outreach and providing education and training to consumers, family members, employers, primary care and healthcare providers, educators, and other responders to recognize and respond to early signs of potentially severe and disabling mental illness. Access and linkage to treatment programs. These programs connect individuals with severe mental illness as early in the onset of these conditions as practical to treatment provided by county mental health programs and other services as needed. Stigma and discrimination rejection programs include activities that reduce negative feelings, attitudes, beliefs, perceptions, stereotypes, and discrimination related to being diagnosed with a mental illness, having a mental illness, or to seeking mental health services. And these program activities increase acceptance, dignity, inclusion, and equity for individuals living with mental illness and their families. Suicide prevention programs include activities that aim to reduce suicidality for individuals at risk of or with early onset of a potentially serious mental illness. Lastly, just like with the CSS component, PEI component funds administrative costs, which include those costs associated with monitoring and evaluating MHSA-funded programs, activities, and projects, and costs associated with conducting and facilitating community program planning processes. And here are some PEI component funding highlights. At least 51% of PEI component allocation must be dedicated to children and TAE who are between the ages of 0 and 25. Counties must have a program within each of the PEI component service categories, except for suicide prevention, which is optional. As mentioned before, county MHSA funding for PEI is 19% or 19 cents of an MHSA dollar. The next component that we will review is the innovation component. This component provides opportunities to try out or test new approaches that contribute to learning by introducing a new mental health practice that has never been done before, adapting or changing an existing mental health practice for a new setting, or introducing a new application of a practice that has been successful in non-mental health contexts or settings. Innovation projects are time-limited and must contribute to learning rather than focusing on providing a service. These are the innovation funding categories. The innovation component will fund projects that increase access to mental health services to underserved groups, increase the quality of mental health services, promote interagency and community collaboration, and or increase access to mental health services. Again, innovation projects must contribute to learning rather than providing a service to fill a gap or need. Innovation projects are time limited, typically between 3 and 5 years. And as mentioned earlier, once an innovation project has gone through a community program planning process and has met the Board of Supervisors approval, they must also be approved by the Mental Health Service Oversight and Accountability Commission, or the MHSA, MHSOAC. The county MHSA funding for innovation component is 5% or 5 cents of one MHSA dollar. The next component we will review is the Workforce Education and Training, or WET component. This component's purpose is to develop and provide programs that enhance the recovery-oriented treatment skills of, and to develop recruitment and retention strategies for qualified mental health professionals and peers and family members providing community mental health services. WET programs aim to address workforce shortages and deficits in the mental health system. WET activities are intended for prospective and current public mental health system employees, contractors, peers, family members, and volunteers. There are 4 WET funding categories, also known as actions. The first one is mental health career pathways. These programs recruit, employ, and support consumers and family members of consumers and community members traditionally unrepresented in the mental health workforce in the public mental health system. Financial incentive programs. These are scholarships, stipends, and loan assumption programs for education expenses that prepare individuals to work in the mental health system. Residency and internship programs. This is for time and program expenses for staff, university faculty to supervise psychiatric residents or postgraduate residents training to work in the public mental health system. And then lastly, training and technical assistance. These are programs that increase the ability of the public mental health system workforce to promote and support the MHSA values or general standards, and to support the participation of clients and family members of clients in the public mental health system, and to increase collaboration and partnerships, and to promote cultural and linguistic competence. To review, in 2008, counties received a local MHSA allocation for WET programs and had through fiscal year 2017-2018 to expend these funds. Currently, the state provides MHSA WET component funding to the California Department of Healthcare Access and Information, or HCI, to enhance the public mental health workforce statewide. After fiscal year 2007-2008, counties may use up to 20% of the average of their 5-year total of MHSA funds to WET actions, to CAPFAC and Tech Needs projects, and or for the local prudent reserve. And counties may contribute MHSA funds to HCI to support regional WET programs and activities. Now we'll review the last component, capital, facilities, and technological needs, or CAPFAC and Tech Needs component. One might consider this component as 2 components. The capital facilities part of this component provides the opportunity to acquire, construct, and or renovate facilities that provide services and or treatment for those with serious mental illness, or that provide administrative support to MHSA-funded programs. The technological needs of this component provides funding for technology projects with the goal of improving access to and delivery of mental health services. The funding categories for CAPFAC and Tech Needs component mirrors the purpose of this component. Capital facilities provides funds to acquire and develop land and or construct or renovate county-owned buildings in which MHSA administrative activities, services, and or supports are provided. And technological needs funds technological needs that enhance counties' ability to provide services and increase access to culturally and linguistically responsive services. To review, like with the WET component, counties received a one-time allocation for CAPFAC and Tech Needs component and had through fiscal years 2017-2018 to use those funds. After which, fiscal year 2007 and 2008, counties may use up to 20% of the average of their 5-year total of MHSA funds to CAPVAC tech needs projects, wet actions, and/or local prudent reserve. CAPVAC and tech needs components also requires that for those capital facility or technological needs projects that benefit more than just the mental health system, the county must braid revenue from other fund sources. Now we will review how the MHSA 3-year program and expenditure plan and annual updates are developed and submitted. The MHSA stipulates that counties shall prepare and submit an MHSA 3-year program and expenditure plan that describes the community planning processes, addresses each MHSA component and component programs and activities, includes data related to county demographics and numbers served through MHSA programs, reports on evaluation results or performance outcomes relating to all MHSA services, and makes expenditure projections for each component for each of the following 3 years. The annual update is an annual plan to the 3-year program and expenditure plan that addresses elements that have remained the same and elements that have changed. It includes data, evaluation results, and performance outcomes from prior fiscal year. It also includes that year's expenditure plan. And other reports that are included in 3-year plans and annual updates include an annual PEI evaluation report and an annual innovation projects report. In short, counties must develop a 3-year program and expenditure plan every 3 years, followed by 2 annual updates, and then that cycle is repeated. The annual update provides program and budget updates to the 3-year plan. A difference between the 3-year plan and the annual update is that the 3-year plan contains budgets per component for 3 years out, whereas the annual update contains 1 budget per component for that fiscal year. The MHSA defines a process for submitting the 3-year program and expenditure plans and the annual updates. The counties must first prepare plans and updates. Then it is required that draft plans and updates are posted for 30-day public review and comment period. At that time, when the plan or update is posted, it is considered a draft. During the 30-day posting period, counties must obtain and collect public comment. The local mental health board conducts a public hearing at the close of the 30-day public comment period. And then following the 30-day public comment period, counties must include a summary and analysis of substantive comments and recommendations in the plan or the update. Counties at that point in time may make substantive changes to the plan or the update if needed. But once this is done, the plan or the update has been finalized. The final plan and updates must then be adopted or approved by the local Board of Supervisors. Plans and updates must be submitted to the State Department of Healthcare Services and the Mental Health Services Oversight and Accountability Commission within 30 days of the Board of Supervisors' approval. The Mental Health Services Oversight and Accountability Commission, or the MHSOAC or OAC, was established by the MHSA, and their primary role is to oversee the implementation of the MHSA across the state. At any time, they may advise the governor or the legislature on mental health policy. There are 6 voting members on the commission, and they include the Attorney General, the Superintendent of Public Instruction, the Chair of the Senate Health and Human Services Committee, the chair of the Assembly Health Committee, and then the following remaining members are appointed by the governor: 2 consumers, 2 family members, 2 employers, law enforcement, school district superintendent, labor organization representative, mental health professional, health representative, physician with alcohol and drug specialization. The OAC's function is to oversee the review and approval process of county innovation plans. They also receive and review all counties' 3-year program and expenditure plans and annual updates for compliance. They review and evaluate the use of MHSA funds. They provide training and technical assistance to counties. They issue regulations for the innovation and PEI components, and they administer the triage personnel grants. For more information about the OAC, you may visit their website, which is listed on this slide. The California Mental Health Services Authority, or CalMHSA, was established during the early years of the MHSA implementation for the purpose of creating a separate public entity to provide administrative and fiscal services that support mental health service delivery for counties who choose to be members. During the early years of MHSA implementation, CalMHSA developed statewide PEI initiatives on behalf of the state. CalMHSA's functions have since grown. In addition to administering statewide PEI projects, they also contract and/or negotiate with the state and other providers of mental health hospital beds or related services. They also contract and/or negotiate with the state or federal government for the administration of mental health services, other programs or activities, manage mental health care, and the delivery of specialty mental health services. They also research, develop, and execute policy requests from members and provide related fiscal or administrative service requests from members. CalMHSA is governed by a board comprised of local county behavioral health directors from each county that is a member. CalMHSA's website is listed here should you want more information about them. And this concludes part 1 of the multi-series MHSA training. Thank you.